very good evening to all of you. Today, our guest speaker for the day is Dr. Jay Mehta from Mumbai. He's going to lecture us on bone marrow trephine biopsy. This webinar is brought to you by Mumbai Hematology Group, supported by RPG Life Sciences Limited, and managed by Perfect Square. I thank Mr. Ajit Mule, Mr. Sudhir Ambekar, and the team RPG Life Sciences, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Jay Mehta from Mumbai, all our discussants who are themselves eminent hematopathologists, clinical hematologists, and medical oncologists, and you participants for sparing your Saturday evening. Tomorrow, that is Sunday, 2nd July 2023, we have a webinar on post-transplant lymphoproliferative disorders at 11:30 a.m. from Dr. Ralph Ulrich Trappe from Bremen, Germany. Let me introduce our discussants for the day, here displayed in alphabetical order. To start with, we have Dr. Akshay Mandloy from TMH HBCH Varanasi, Dr. Amrita Saraf from Sir Gangaram Hospital, Delhi, Dr. Ankur Ahuja from AFMC Pune, Dr. Deepak MB from MSMC Narayana Health City, Bengaluru, Dr. Jyoti Bajaj Sone from Gujarat Cancer and Research Institute, Ahmedabad, Dr. K. Gayatri from Tapadia Diagnostic Center, Hyderabad, Dr. Parimal Sharda from Unipath Specialty Laboratory from Ahmedabad, Dr. Pratik Bhatia from PGI Chandigarh, Dr. Pulkit Rastogi from PGI Chandigarh, Dr. Rupam Deka from AIMS Guwahati, Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, Dr. Sindhura Lakshmi from Manipal Academy of Higher Education, Manipal, Dr. Subhajit Hajra from AIMS Rishikesh, Dr. Sundar Shivale from TMC Kolkata, Dr. Tushar Sehgal from AIMS Delhi, Dr. Udyan Khachi from Vadodara, Gujarat, Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center, Mumbai. Now it's a time to introduce our guest speaker for the day, Dr. Jay Mehta from Mumbai. Dr. Jay Mehta is President and Head Surgical Pathologist, Oncopathology from Newburgh Oncopath, Mumbai. He's going to lecture us today on bone marrow trephine biopsy. Well, thank you so much. Over to you, Dr. Jay Mehta.
Hi, thanks, Dr. Amit, for introduction. I'm going to start sharing now. Okay, so I'm going to briefly kind of take you through what my concepts of decoding the bone marrow trephine are. So this is not necessarily something that which is probably there. Everything is there in the textbook. It's something which I have learned across my journey about looking at trephine biopsies. So the word trepenon derives from the Greek. The trephine, the word the trephine comes from the Greek trepenon, which means an instrument for boring. So that's why we call it a bone marrow trephine. Now, the talk will be kind of structured when in such a way that I'm going to talk on why should one obtain a trephine biopsy, what do you look out for in a trephine biopsy, who stays where, which means what cells stay where in the trephine, how do you diagnose myelodysplasia, and role of immunohistochemistry in trephine biopsy diagnosis. So when is a trephine biopsy important, which means that when is actually a bone marrow trephine biopsy done? So you do it when the marrow is packed, as in acute leukemia, or you have a dry marrow, as in aplastic anemia. Or if the marrow is fibrotic, that means, in cases such as myelofibrosis, where you have metastasis, or marrow involvement by non-Hodgkin lymphoma. I think Kalpesh needs to switch off his microphone. You do it for myelodysplasia to assess for blasts, the overall cellularity and the marrow fibrosis.
Kalpesh, can you please switch off your microphone?
1st July માં જે બ્રોશર ની અંદર હોય તેની વાત કરો.
Kalpesh? Kalpesh, can you please switch off your microphone? Let me call you. Kalpesh, can you please switch off your microphone?
Video link જણાવે તેની વાત કરો છો.
Just a minute.
हाँ जॉइंट वेबिनार लिंक हाँ 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 ओके हाँ
Okay, hopefully he's switched off the microphone. So
Yeah.
continuing from there, so after myelodysplasia, when you assess for blasts, cellularity, overall cellularity, and the fibrosis, you might want to do a trephine biopsy for evaluating myeloma involvement, the tumor burden, and to do the light chain restriction evaluation. It could be done for staging lymphomas, and importantly, after therapy is initiated, chemotherapy, to determine any aplasia or the quantum of regeneration. So what's the adequate length of a trephine biopsy? Typically, you would get about a trephine which is 1.5 centimeter in practice, but textbooks would say you should get something optimal length of 2 to 3 centimeters. That doesn't always happen. You should at least have, so I'm just saying that's the bare minimum, 5 to 6 intertrabecular spaces for evaluation. At the same time, let's be aware of a tangential biopsy. So here's a tangential biopsy, and it's quite long. It would fit the optimal length criteria, but you can see it's tangential. It's gone kind of, parallel to the bone. So what you have is basically the cartilage here and this subcortical little marrow. So this is not enough for evaluation because you wouldn't know if that's really representative of the entire marrow pathology. So subcortical marrow is a zone of physiologic hypocellularity, which is marked here in this thing. This is the periosteum and the subcortical region. Now this, if you have a short length marrow, and you would probably erroneously report it as a aplastic marrow. So one should be aware of this subcortical zone of hypocellularity. Now, also important that subcortical fat may actually be respected by neoplastic processes. And why do I say that? Here's a case of a CML, and you can see that this is the whole marrow is practically involved by CML, but the subcortical spaces have been spared here. So the long and short of it is that if you do get something which is of suboptimal length and it's just basically subcortical, you may be missing the tree for the woods. There's something which is below there which you don't know what's happening. So please always discount the subcortical spaces. Also, it's very important to look at the bony trabeculae. Sometimes that gives you a hint as to what's happening. This trephine was done for a 6-month-old female child who had prolonged anemia. And what you look at the bone marrow is remarkable for this bony trabeculae, which has these blue islands of bone amidst this trabecular bone. This is very typical of osteopetrosis. And since this was suggested, a whole exome sequencing done for this child showed a homozygous mutation in osteopetrosis related gene. So there are things which you can pick up also by looking just at the trephine biopsy's bony component. Now here's another bony area where you can see that there's remodeled bone. You can see this remodeled woven bone, which is starting to get lamellar at the periphery. And you can see here there is a metastatic disease in the marrow here. So that's causing this kind of osteoblastic activity, lytic and blastic activity. And then you may get this very peculiar finding of this bony trabecula, which are anastomosing, and they are very thick and they are very prominent osteoid seams. You can see this osteoid seams. Typically, you tend to see maybe one or so per trabeculum. Here, it's actually 1, 2, 3. They are crisscrossing. Look at the thickness of this bony trabecula, very thick. And you can see this anastomosing pattern. All the trabeculae seem to merge and anastomose into each other. This is a picture which is typically seen in primary myelofibrosis and Paget's disease. Likewise, you can see bone marrow abnormalities when you have renal failure as well. So there's much to glean from even staring at the bony component of the trephine biopsy. So what are the fixatives that one may use? You can use buffered formalin. You can use the fixative called AZF, that's acetic acid, zinc formalin. You can use Bouin's fluid. Now, Bouin's fluid can be used, quite popular with some of the labs, but it tends to harden the tissue. So I personally don't prefer using it. There's B5, but that's kind of antiquated now. And what are the decalcifying agents that one could use? One can use 5% nitric acid, 10% formic acid. I like that. It's very good. It's very gentle on the trephine. You can use EDTA. Now, EDTA can be used if you're looking for some kind of a molecular analysis from the trephine biopsy. It preserves the genomic DNA much better as compared to 10% formic acid. People even use concentrated hydrochloric acid. It is very fast decalcification, but it spoils the morphology. So one should avoid doing that. People want to do it so that then quickly kind of report on the trephine biopsy, but that's something that comes at a price. You lose the morphological details on that. And for some of our junior colleagues in the audience, I refer you to this paper, which is free to download. It's a Journal of Clinical Path paper by Professor Naresh on optimal processing of bone marrow trephine biopsy, the Hammersmith protocol. That's what I personally follow in my lab, and many labs in India anyway follow this. So I think it's worth, if people who haven't really had access to this, I would urge you to download this. It's a free to download paper on the net. So a section cutting, you can use paraffin, you can use resin. Ideally, a section should be cut at 2 to 3 microns to judge the individual cells in the trephine biopsy. How do you judge the cellularity? It's related to the age of the patient, and the rule of the thumb is that cellularity is 100 less the age of the patient. As I said, again, ignore the first 2 subcortical spaces. These are physiologic zones of hypocellularity. Look at the bony trabeculae, you might get, as I said, indications for Paget's disease, osteopetrosis, primary myelofibrosis. So it's very important to look at low power, all these findings. The usual ME ratio in adults at least is 3 to 4:1, which means there's more myeloid than erythroid series. And you tend to see about 2 to 4 megakaryocytes per high power field. So this is a quote which kind of gels in my head. This is quoted by Professor Barbara Ben. Except in extreme old age, cellularity of less than 20% is likely to be abnormal, as is cellularity of more than 80% in those about 20 years of age. So this is something that you can keep in mind. So except in extreme old age, cellularity of less than 20%, more likely to be a hypoplastic or an aplastic marrow. And if it's more than 80% in those who are about 20 years of age, there's something wrong with the marrow and it's markedly hypercellular, and you have to look for the underlying cause. What about lymphocytes in the bone marrow? Typically, you might see this kind of lymphocytes in about 5 to 10% of adults. The B cells and the T cells, the ratio is 1:4. So T cells outnumber B cells, and the CD4 to CD8 ratio, CD8 outnumbers CD4 by about 1:3:4. The lymphoid aggregates, if they are benign, they're usually very few in number. They're rarely numerous if reactive. They tend to increase with age. So you tend to see them more in trephine biopsies from elderly patients. About a third of marrows in elderly patients show you lymphoid aggregates. You tend to have more of T cells than B cells. You may or may not see germinal centers. Typically, reactive lymphoid aggregates are non-paratrabecular in location, unless there is a pathology present in the marrow to distort the stroma and push the lymphoid aggregates towards the trabecular spaces. So here's a picture of a trephine biopsy showing a lymphoid aggregate. You can see this in H&E, this lymphoid aggregate. CD20 showing the small lymphoid cells, and bulk of them are accounted for by the CD3 expressing T cells. So benign lymphoid aggregates, as I said, are common in elderly individuals, increase in frequency after the age of 50, and are of unknown clinical significance. They are often identified in bone marrow biopsies from patients with autoimmune disorders such as rheumatoid arthritis, SLE, autoimmune hemolytic anemia, or ITPs. And I probably think it's because of a reaction to the immune phenomena. They also at the same time will have lots of plasma cells. HIV infection is another infective disorder where you will see lots of benign lymphoid aggregates. Now, these may also be seen in kind of concurrence with the chronic myeloproliferative neoplasms, particularly primary myelofibrosis. Rarely, you may even see them with myelodysplastic syndromes. Now, benign aggregates are usually single or few in number. They're distributed randomly away from the bony trabeculae and are typically round and well circumscribed without any significant interstitial spillage of lymphoid cells. The reason I'm telling is that a lot of times I get referrals for evaluating lymphoid cells in the trephine biopsy, and these are a few soft pointers which you can use to determine if something is malignant or reactive. Now, lymphocytes within the aggregates are usually small and mature appearing with round nuclei, condensed chromatin, which means it's a mature chromatin, and typically no nucleolus or inconspicuous nucleolus. The aggregates are frequently polymorphic and may contain histiocytes and plasma cells, the latter more so if you have an autoimmune condition associated. Often you will see a small vessel which is visible within the aggregate. Germinal centers are rare, but when they are present, they usually indicate that the lymphoid aggregate is benign. There's a caveat here. You can get this reactive lymphoid aggregate surrounded by marginal zone cells, and that happens when you have marrow involvement by splenic marginal zone lymphoma. So what about hematogones? Now, these are the precursors to the B cells, and they might mimic blasts of ALL. Now, these, what's the other pointer to kind of see it on morphology? They are of variable sizes. And if you do immunohistochemistry, the staining intensity varies. They have a peculiar phenotype whereby CD10 is expressed by a majority of the cells. Lesser so is PAX5, even lesser are CD20, TDT, and CD34. And believe me, it's difficult to pick them up on morphology alone. And here's a marrow here, which you can see there's some erythroid cells. You can see some lymphocytes sprinkled. You can't swear and say, what are the hematogones in this? And if you did this kind of a staining pattern, you can see the CD10 on the top left is quite high. It's marking a lot of lymphoid cells. A proportion of them are marking with PAX5, smaller proportion with 20, and so on and so forth with TDT and CD34. So this is the same kind of staining intensity or the pattern that you would get in a waterfall plot in a flow cytometer. So that's how you identify hematogones. Now, when do you see hematogones? Typically past infancy, because normally in infants, you might see lots of hematogones. So you can see them post-chemotherapy and post-transplant setting, autoimmune conditions in association with untreated lymphoma. So when you have staging marrows, which come up sometimes, and you will see this hematogones. Very peculiarly, you can see them in association with chronic myeloid leukemia. CMV infection is something else which is associated with hematogones. And sometimes you see hematogones for really no apparent or good reason. You cannot ascribe a cause to the presence of hematogones in a lot of cases. What about plasma cells? Normally about 2 to 3% in the marrow with a kappa to lambda ratio of 3 to 4:1. And they tend to show distinct perivascular localization. If you see lots of plasma cells which are aggregated in the marrow interstitium, that should worry you for a plasma cell neoplasm. So this is CD138, which is a stain for plasma cells, and you're seeing this aggregated around the vessels. Coming to blast cells, you'd enumerate the blast cells by doing two markers, CD34 and c-KIT, or CD117, which is a stem cell marker. Typically, you will see about overall marrow anywhere between 1 to 3 or 4% of cells which mark with CD34, which is normal. And if you really start to count, then you will see about 1 to 2 cells every 2 high power fields. Now, CD117 tends to mark more cells than CD34 because it will also mark, in addition to myeloid progenitor cells, it will mark plasma cells, megaloblasts, and mast cells. Amongst this, mast cells takes up the heaviest intensity of CD117 staining pattern. So here's the CD11 staining, and you can see this very intense bright staining is in plasma cells, and the very dim and faint membranous staining, these are all megaloblasts. So these are the ones which are showing you dim positivity. Likewise, for CD34, this is a vessel which is marked endothelial cells. You can see this one, and there are two, and maybe a kind of a 34 expressing cell here. So you can see about 1 to 2 cells per every alternate high power fields. What about reticulin assessment? It has to be graded. You can use a lot of kind of consensus kind of criteria. I use the European Myelofibrosis Network. That's the EUMNet consensus on grading myelofibrosis, where the grades range from MF0 to MF3. MF0 basically means that it's a normal bone marrow. There is hardly any increased intersections of reticulin condensation. MF1 is an increase in loose network of reticulin with intersections, particularly in the perivascular areas. Myelofibrosis 2, that's grade 2, is diffuse and dense increase in reticulin with extensive intersections, and occasionally with focal bundles of collagen and focal osteosclerosis. If you have diffuse and dense increase in reticulin with multiple coarse bundles of collagen, that is usually a grade 3 pattern of myelofibrosis, and you will also see osteosclerosis along with that. So here are pictures of normal reticulin. See here, it's an internal control. That's the perivascular area, which is picking up the reticulin fibers. Otherwise, very few reticulin fibers, no intersections. Here's a grade 1 reticulin fibrosis pattern. There is diffuse, not diffuse, but there are localized intersections. and there's more diffuse intersections in grade 2. If you did a collagen stain, you might see very focal deposition of collagen. In grade 3, there is diffuse dense intersections. You can readily identify a grade 3 myelofibrosis. The bone, bony trabeculate tend to be thick. There's osteosclerosis. And if you do a collagen stain, you will see lots of collagen deposition in grade 3 myelofibrosis. The reticulin has to be assessed only in the hematopoietic areas. You need to exclude areas of lymphoid infiltrates, which inherently by nature will have increased reticulin deposition. You will have fibers around blood vessels, which act as internal control. So you shouldn't be counting that as reticulin fibrosis. And fibers which frame adipocytes are also a routine thing. So you shouldn't be using that to grade the reticulin fibrosis. So the secondary causes of myelofibrosis include myeloid neoplasms such as chronic myeloid leukemia, essential thrombocythemia, polycythemia vera, MDS. You can also get it with AML M7 and mast cell disease. Lymphoid neoplasms, particularly hairy cell leukemia, and some of the other lymphomas will show you increased reticulin deposition. Non-hematologic conditions for secondary causes of myelofibrosis include metastasis, metastatic disease, autoimmune disorders such as SLE, rickets, renal osteodystrophy, and infections can also cause a lot of reticulin fibrosis. So when you see increased reticulin fibrosis in a young person, look at the bony trabeculae and also try to figure out if that's not a kind of a metabolic bone disorder such as rickets, which is causing that myelofibrosis and the bony changes. So myelofibrosis predicts early marrow failure in myelodysplastic syndromes. In all subtypes of myelodysplastic syndromes, the overall survival is markedly reduced when myelofibrosis has occurred. So, and that's irrespective of the blast count. So it's very important to offer a reticulin fibrosis grading at least in a myelodysplastic syndrome setting. Now, practical reasons for marrow examination in practice include when a patient has pancytopenia, or the patient has anemia, thrombocytopenia, pyrexia of unknown origin, there's a paraprotein discovered in the serum, there's elevated WBC counts, or if you want to do any lymphoma staging or leukemia evaluation. So after pancytopenia, anemia is the most common indication for marrow examination, usually done after nutritional profile has not been contributory. That means iron, B12, and folate levels have not really contributed much. Sometimes hopefully the hematologist would have excluded toxic, metabolic, and drug causes of anemia, because that's certain, some of the things you can't really pick it up on marrow morphology alone. The prime reason for marrow examination of excluding all above is to diagnose myelodysplastic syndrome. Two neoplasms which can present as anemia are hairy cell leukemia and lymphoplasmacytic lymphoma, and so does myeloma present in the same way just as plain anemia. Thrombocytopenia, myelosuppression due to drugs or toxins. So that's something that you can glean by getting a detailed history, but you will see decreased megakaryocytes in the marrow. Or if there is peripheral platelet consumption, such as in ITP, when you have antiplatelet antibodies, normal to increase megakaryocytes in the marrow is something that you will see when you have ITP. Rarely there are anti-megakaryocyte antibodies, and the marrow shows reduced numbers of megakaryocytes. Remember that MDS seldom presents as isolated thrombocytopenia. So refrain from calling something as MDS when you see a dysplasia only in the megakaryocytic lineage. So other causes of evaluating marrows would be when you have elevated peripheral counts, such as with leukocytosis, whether the clinical query is if it's CML versus reactive, or is there a leukemia. When there is erythrocytosis, so it's polycythemia vera versus a secondary polycythemia, such as the one you would get with a smoker. When there is thrombocytosis, so distinguishing MPN versus a reactive marrow, or when the megakaryocyte morphology has to be evaluated to check for MPNs. Paraprotein causes in the marrow include myeloma in about a third of the cases, about 10% of the cases, non-Hodgkin lymphomas. Half of MGUSs can be evaluated, can be confidently checked on the marrow. Sometimes you have a paraprotein which has no apparent cause in 5% of the cases. You'll not find a reason for that by evaluating the bone marrow. A higher level of paraprotein makes positive bone marrow finding more likely. The type is also very important. If you have an IgM paraprotein, then it's more likely to be a lymphoplasmacytic lymphoma or a B-cell non-Hodgkin lymphoma, such as a marginal zone lymphoma. Myelomas are rarely IgM positive. If it's IgG, IgA, or IgD paraprotein, it's usually a myeloma or a B cell lymphoma, but rarely a lymphoplasmacytic lymphoma. So it matters what is the heavy chain restriction that you have discovered. So coming to marrow topography is paramount in assessment of marrow trephine. The cells of the marrow are distributed in a non-random fashion. They're not randomly distributed. They all have a non-random distribution. They reside in a designated place, well, most of the times. In a very highly dynamic environment, any deviation from normal helps in interpretation of a disease state. So that means there's a topographical abnormality that helps you in diagnosing a disease. Immunohistochemistry is invaluable in judging marrow topography on a trephine biopsy. So here's a trephine biopsy. I saw this picture in a conference when I had gone overseas, and this is actually an autopsy table on which is lying this dead body, and somebody's actually painted it marrow on this autopsy table. So I found it very intriguing, and I photographed this, and I use it for almost all of my trephine biopsy presentations. So it's very ironic that who resides where, and here is this person who is deceased and lying on this autopsy table, and we're trying to decipher who resides where on the trephine biopsy. So the landmark for deciding and checking where these cells reside is the bony trabeculum, the bony spicule. Close to the bony spicule, you will see this osteoblasts, which on morphology resemble plasma cells actually. Then you have these myeloblasts, promyelocytes, myelocytes, metamyelocytes, and mature granulocytes towards the center of the marrow. So this forms the paratrabecular promyelocyte-myelocyte zone. Then you have this erythroid islands, which lie towards the center of the marrow. The megakaryocyte lies towards the center. Then you have this plasma cells, which are pretty much adjacent to vessels and capillaries. If you do find interstitial lymphocytes, couple of them or aggregates that tend to be towards the center of the marrow and not towards the paratrabecular space. And here's the sinusoidal lumen. So this is the bone marrow topography. These are actual pictures. You can see this immature myeloid cells, which are all, this is the paratrabecular promyelocyte-myelocyte zone. Some of the myeloblasts you might even find towards the center of the marrow, but that's something which is not very typical. The maturing myeloids will start from this, where the paratrabecular promyelocyte-myelocyte zone ends, and towards the center of the marrow. So the maturing myeloid cells are here. Then you have this erythroid cells, which are again towards the center of the marrow. You can see this normoblast with ink dot, kind of ink blot chromatin. You can't see through this chromatin. These are the erythroid cells. The megakaryocytes you can see here reside towards the center of the marrow. So if you keep this at the back of your mind in evaluating a bone marrow, if there is any deviation from this normal, that takes you towards trying to identify or decipher an underlying cause for that displacement of the residents. So these are normal maturing erythroid islands in this center. You can see this dense chromatin. You can't see through them. These are all normoblastic erythroid cells lying towards the center of the marrow. You can see normal megakaryocytes. Don't need to tell you, this is the largest cell in the marrow, multilobate cell. You can see about 2 to 3 per high power field. This is something that you might come across. You can see this emperipolysis in a megakaryocyte. That's a perfectly normal finding. So don't beat yourself over, trying to find out what's happening, but there's a normal kind of physiologic finding. So here's the normal paratrabecular promyelocyte-myelocyte zone. See, these are all the myeloblasts and the promyelocytes, which are then giving rise to the mature cells toward the center of the marrow. This is quite a sacrosanct area. It tends not to be disturbed unless there is some kind of a reactive process or a chronic myeloid leukemia. Here's MPO highlighting the myeloid cells in the paratrabecular region. And here's the expanded paratrabecular promyelocyte-myelocyte zone in a chronic myeloid leukemia. You can see how thick that is. And you don't see any maturing myeloids coming out of this zone, which is typically this, it's about 3 to 4 cell layer thick. And you can see now it's really expanded. So you can see all these cells. So paratrabecular promyelocyte-myelocyte zone can also sometimes be expanded in reactive conditions, but that's something that you'll be able to pick out and distinguish from a CML in any case. So myelodysplasia is a clonal stem cell proliferation. There is ineffective hematopoiesis. There is abnormal maturation. There is a peripheral cytopenia. It could be unilineage. It could be bilineage. You can have a trilineage thing. So it's pancytopenia. And the bone marrow itself may not always be hypercellular. Sometimes it's normocellular. And in about a proportion of cases, about 10 to 15%, it can even be a hypocellular marrow. So how do you recognize myelodysplasia? You look at the architecture and the maturation. You look at, in the architecture, the overall disorganized appearance and deviation from normal site of residence. And for maturation, you look at the nuclear cytoplasmic changes. So here's a cartoon depicting a myelodysplasia. What's different here? That's the kind of a landmark. You look at the trabecular bone here. Then you can see these erythroid cells are here. They're not supposed to be lying here. The megakaryocytes, they're also going towards the paratrabecular space. That's a short sign that there's something wrong going on with the megakaryocytes. And look at this myeloid precursor from the paratrabecular space. They're coming into the center of the marrow. So that's something which is not seen. Megakaryocytes tend to be towards the sinuses normally, but if they are displaced towards the paratrabecular space, that is something abnormal. And you can see this landmark here. So I always look at the trabeculum here, and you can see the trabeculum here. What do you see? This erythroid island very close to the trabeculum. This megakaryocyte, it's enlarged, it's monolobate, and it's sticking quite close to the bone. So that's also something which you would see in a myelodysplasia. Here's a center of the marrow showing lots of myeloid precursor cells here, this blast. That's probably an ellip, and that's also kind of going towards a diagnosis of myelodysplasia. So how do you judge erythroid dysplasia? Erythroid islands tend to be either too small or too large. Megaloblastic maturation is a sign of dysbiosis. There's an asynchronous maturation between the nucleus and the cytoplasm, which means there is early hemoglobinization. That's a sign of erythroid dysplasia. Or when you have multinucleation, if you see multinucleated erythroid cells, that's also a sign that something's wrong with the erythroid cells. So here are all megaloblasts in the bone marrow. How do you identify them? They tend to have round nuclei. You can see this very pale chromatin, and you can see this nucleoli, very fine, not very prominent, but they are eosinophilic nucleoli in these cells. So that's megaloblast, and you can do immunostain to confirm it by glycophorin C or CD71, whatever the lab has. That tells you that it's a megaloblast. And here's a whole bunch of dyspoetic erythroid cells. Here are pronormoblasts. You can see them. You can see some of these early normoblasts. You can see multinucleation. It's almost like a polymorph here, a trilobate cell. You can see this nucleation, multiple nucleation. These are very dyspoetic erythroid lineage in this cartoon here. So that's something that you can pick up if the section has been cut really thin. You need to cut at 2 or 3 microns to appreciate this kind of abnormality. How do you assess for myeloid dysplasia? You can look for ellipse at least, which means that at least 3 clusters of myeloid precursors in the center of the marrow space. And you would then need to do a CD34 or a CD117 to document the ellipse. You can identify dysplasia if there is a left shift of the granulopoietic lineage, which means you're seeing left shifted myeloid progenitor cells. Now, things which are difficult to assess on trephine are hypolobation, hypersegmentation, hypo or agranularity or hypergranularity. These are changes which are best appreciated on an aspirate cytology. So here's left-shifted granulopoiesis depicting myeloid dysplasia, MTO on the left showing that all of these blasts or the left-shifted progenitor cells are myeloid in origin. Here's something ellipse, but you cannot swear and say there are ellipse here unless you actually did this kind of a stain. So this is CD117. You can see these clusters of 3 or more cells jutting towards each other, and this is ellipse. Even more confirmatory would be to do a CD34, and you can see this cytoplasmic granular positivity in this bunch of cells here. These are all ellipse. Now, how do you assess megakaryocytic dysplasia? By virtue of being such a large cell, it tends to attract your eye when you're looking at the trephine biopsy. So if something is displaced towards a paratrabecular space, that's dyspoetic megakaryocyte. Then if they are clustered, typically you only see 2 or 3 per high power field, and they are far away from each other. If they are clustered either loosely or tightly, that's dyspoetic. How do you determine it's loose clustering? That means there is some intervening hematopoietic tissue. When there is no intervening hematopoietic tissue, that's a tight cluster. If the nucleus of the megakaryocyte is hypo or hyperlobate, that gives you an indication of dysbiosis. Micromegakaryocyte, if you identify micromegakaryocytes, that's almost certainly dyspoetic megakaryocytic lineage. These are mononucleate megakaryocytes with a size comparable to promyelocyte or even less sometimes. And they lack features of a blast cell, and they also mark with CD61. And then if you can identify megakaryoblast, that's almost certainly a dyspoetic megakaryocytic lineage. So here's this megakaryopoiesis. You can see megakaryocytes of varying sizes, ranging from something which is medium size, something which is small here, to something which is huge. You can see there is this is hypolobate. You can see this very bulbous look to it. And you can see there is some hyperlobation here. So there's something wrong. There is an asynchrony between the nucleus and the cytoplasm. And here is something which is difficult to appreciate directly seeing on the trephine biopsy, but there are several micromegakaryocytes in this marrow, and you can identify them when you do a CD61 immunostain. So you can see that all these cells are probably micromegakaryocytes, and you can't pick it up directly on a morphological grounds. So while we are on the topic of megakaryocyte morphology, I wanted to share these images with you of these different megakaryocyte morphologies that you see in myeloproliferative neoplasm. So when you have this staghorn-like enlarged megakaryocyte, that's typical of an essential thrombocythemia. When you have megakaryocytes of variable sizes, a very polymorphous population, that happens with polycythemia vera. When you have this bulbous hypolobate megakaryocyte, that happens with myelofibrosis. And this very dwarf nuclei are something that you will see always in chronic myeloid leukemia. So megakaryocyte morphology is very important to determine what's going on in the marrow. And for myeloproliferative neoplasms, it's invaluable to assess the megakaryocyte morphology. Now, coming to aplastic marrow, the word aplasia connotes total fatty replacement of the marrow. Truly aplastic marrow, however, is rarely completely fatty. It almost always harbors some plasma cells, lymphocytes, clusters of macronomoblastic erythroid cells, and scattered macrophages. Megakaryocytes are exceedingly uncommon in an aplastic marrow. If you see them, try to look for micromegakaryocytes or dyspoetic megakaryocytes, because if you see them, then it's unlikely to be an aplastic marrow, but a hypoplastic MDS. Always ask for history of therapy before labeling something as an aplastic marrow on your histology report. So how do you distinguish morphologic dysplasia versus myelodysplastic syndrome? Morphologic dysplasia, avoid calling MDS by trying to find or ascribe a possible cause for the dysplasia. Do not put too much emphasis on unilineage dysplasia, particularly if there is only megakaryocytic dysplasia. Now, clues to avoid missing MDS are if you have excess blasts in the marrow, or there's a cytogenetic abnormality, or there is a strong clinical evidence to suggest MDS, such as refractory cytopenias. That's something which should make you look very carefully and hard in the trephine to find out the cause for that refractory cytopenia and determine the underlying MDS. So what's the threshold for calling something dyspoiesis? So the textbooks would say the threshold limit is 10% of cells in any lineage. I think that holds good for erythroid and myeloid lineage, but for megakaryocytes, I would recommend that at least 1/3 or about 40% of them show some dyspoiesis, because by its nature, it's such a large cell, depends on the way it has been cut in section cutting, it will show you some kind of a nuclear abnormality, and one shouldn't put too much emphasis on that and start calling marrows as dyspoetic in nature. Now, compounding the issue with the above is the fact that dysplasia is not very specific for MDS. You can have secondary causes for dyspoiesis. And rather importantly, dysplasia is not always reproducible between two pathologists also. So what's the utility of doing immunohistochemistry in trephine biopsy? There are some specific stains you can use, things like CD71, which will enumerate the erythroid lineage, myeloperoxidase for myeloid lineage, either CD61 or 41 for megakaryocytic lineage. These stains give you an overall distribution of the cell lineages. You can get a basic idea of the ME ratio. You can get ideas and diagnose megaloblasts, determine ellipse, micromegakaryocytes. You can assess blasts in MDS and MPN by using CD117 and CD34 as the blast markers or stem cell markers. You can use the immunohistochemistry also for lymphoma, leukemia, and myeloma assessment. Now, sometimes you have discordance between aspiration, cytology, and trephine biopsy, and it does happen at times. Now, focal pathologies such as paratrabecular lymphoid infiltrates or plasma cell aggregates will obviously be underrepresented in aspirates. Now, criteria for recognizing leukemic blasts are better defined in aspirates and on trephine biopsy, and so is counting of cells. You can't count a cell very accurately on a trephine biopsy. And sometimes there are just genuine sampling differences. It all depends where the marrow has been sampled from. But there's a rule of thumb. If something is seen in trephine sections, it may be absent from the aspirate, but if something is found in the aspirate, it really should also be seen in the trephine biopsy specimen. Now, there are some unmet needs of a marrow trephine. Sometimes there are unrealistic expectations from trephine biopsy reports, post-treatment marrows for residual disease. Really, trephine biopsy is not a sensitive tool for something which has less than 5% blast. If something more than that, yes, you can actually say something about the residual disease. There's also a problem if it's marrow which is being evaluated post-chemotherapy for assessment of leukemic blasts. Blasts are blasts on trephine. You can't make out if it's a leukemic blast or a regenerating blast. So that's something that you can probably do on a flow cytometry, because you can see the subtle nuances of the expression patterns of various antigens or antibodies on it. You can't accurately classify AML on the trephine biopsy. And megaloblastic dyserythropoiesis, sometimes you can't find out what is the underlying cause. Is it genuinely only megaloblast because of B12 or folate deficiency? Or is it to do with MDS, or there's a different cause for it? Not everything is countable on trephine. So that's something which shouldn't be expected from a trephine biopsy. So to wind up, that's the synopsis. Why do we do a trephine? You do it when there's a dry tap. When you do that to assess cellularity, overall cellularity. One does a trephine to assess the spatial distribution of hematopoietic cells and the relationship with respect to the stroma and the bone. Bone is also a very good indicator of underlying metabolic disorders. So also look at the bony trabeculae. Focal nature of disease. If you have patchy lymphoid infiltrates, that's something that the aspirate cytology is going to find it difficult to pick up. So the trephine biopsy is useful in that case. Patterns of infiltrates, very important. Something like a splenic marginal zone lymphoma, where it has intrasinusoidal localization of lymphoid cells, is brought out beautifully by doing a CD20 immunostain. You can do immunostains for various other things, such as, it helps you in assessing individual cell lineages, the topography, diagnosis of myelodysplasia, recognizing the blasts, ellipse, to stage lymphomas, leukemias, and myelomas, or to identify infiltrates such as metastatic carcinoma. And rarely, when you have a mast cell disease, it's very useful to do immunohistochemistry on trephine biopsy. So remember, friends, it's not always easy to judge if a marrow is normal. It does take time. It takes a lot of patience to evaluate a trephine biopsy. Distinguishing reactive from neoplastic processes poses challenges because of overlap in morphologic appearance of various. You might have a short viral infection. It could be a CMV or a EBV. And for some reason, if the marrow has been done after that, it really looks very, very dyspoietic. And you need to know that clinical history definitely before calling something as dyspoiesis. For marrow pathology, morphology has to be supplemented with ancillary studies to arrive at a correct diagnosis. So you have to match it with the aspirate cytology slide, sometimes also with the cytogenetic findings and with flow cytometry to come at a correct diagnosis and the overall picture. And lastly, diagnostic accuracy is really enhanced if you talk to the hematologist or the treating physician. You tend to get lots of information and clinical details from them, which helps you actually identifying the underlying disease or what is going on in the marrow. So thank you for your patient hearing on this Saturday evening.
Thank you, sir, for that fantastic and superb lecture, as always. It's always learning from you. Every point is worth learning from you, sir. Thank you so much. What a wonderful lecture.
Thank you. Thank you.
So we have our colleagues over here who are going to discuss with you. So I start off with Dr. Parimal Sharda. Dr. Parimal Sharda, your question, please.
Jai bhai, nice talk.
Thank you.
It's always excellent talk.
Parimal bhai, I think we are losing your connection. I can't hear very well.
Okay. Now, I am audible?
Yes, now you're audible.
Much better now, yes.
Yeah. So I want to know role of KX67 in trephine biopsy.
So
and whether it is useful to...
No, sorry, please.
Whether it is useful to differentiate between low grade and high grade, because sometimes clinician ask, you do the KX67 and tell me the percentage.
No, it's very difficult to do it because marrow has so many cells. it would be useful is probably if there is a mantle cell lymphoma involvement in the marrow, and that also a substantial amount where you can actually map that area in that Ki67, and you would do it. But no, I mean, unless, you know, it's maybe a Burkitt lymphoma involvement or something, you would want to do a MIP1 or a Ki67. No, I don't think it should be done. And it's even if it's done, it's very difficult to interpret what cell is actually kind of labeling with Ki67.
And one second question, that sometimes the lymphoplasmacytic lymphoma can present with the more lymphoid aggregates as compared to the plasma cells. So then the dilemma is come whether we are dealing with LPL or whether we are dealing with marginal zone lymphoma with plasmacytic differentiation. So how to differentiate in this?
I think that's a very good question. So marginal zone lymphomas or any low-grade lymphoma can show you plasmacytic differentiation. So one is, both of them will show you some kind of a light chain restriction. A simple thing would be to do the check for IgM. If it's IgM, then it's more likely to be a LPL and a Waldenstrom. But again, as I said, you will have to have some ancillary testing like a MyD88, L265P point mutation, or do the serum protein analysis and various things. So I agree with you. I don't think we can give a very definitive answer if there is a very small plasma cell component and a huge lymphoid component. That is something we are not going to be able to tell you much beyond that.
Thank you. Thank you very much.
Thank you, Dr. Parimal Sharda. Dr. Amrita ma'am, your question, please.
Beautiful lecture, Dr. Mehta. It was really nice to hear all the details of including basics and challenges when we report on trephine biopsy. So I would like to highlight a couple of things here. It's like my comments that what I understand, like sometimes we have flow also, we have bone marrow biopsy also, we have peripheral blood also. But just as a suggestion for our trainees and for our postgraduate students and all the audience, that one should not forget the basics of the clinical details, because many a time the clinician want us to comment on the biopsy, but we don't have the proper clinical details, followed by morphology on the peripheral blood, then bone marrow aspirate, then biopsy, and then if possible, if we have a luxury of flow cytometry and molecular, then we should go towards that. Upon that, imprints. So there is a difference of opinion. Some people really want to provide us imprints while taking the biopsy, but some people simply don't like. As far as my own experience is concerned, I think imprints should be interpreted very wisely because they have their own challenges, sometimes artifactual challenges, defects, which can misguide a person. And biopsy takes usually more time. It takes 2 more days. So what my suggestion is, imprint is always good to have, because sometimes when there is a dry tap or like there are focal distribution, then imprint can give us a clue towards a quick pointer towards a diagnosis when biopsy is taking time. But one should be very, very careful in terms of interpreting imprints, and one should not make mistakes in judging the bare nuclei and those naked cells, because smudging and artificial changes in the morphology can actually misguide one. Ki67 helps. To my experience, like we usually go in a stepwise process. Like first is H&D. After doing the marrow aspirate, we get the H&D, and then there is an indication, because flow cytometry sometimes gives us a correct diagnosis, but many a times it is the distribution and topography, what you correctly highlighted, helps us. But Ki67 as a pointer of proliferative index, it helps. Maybe Gayatri ma'am can highlight it because she has a vast experience in interpreting all these complicated cases. Ma'am, what would you like to say on Ki67 as per your experience?
Thanks for that, Amrita. I really haven't, I don't use Ki67 for the same reason as what Dr. Jay was mentioning. There are too many cells that are in that zone, so you do not know what you are actually interpreting as a high count. So the risk is of, counting more than there are. So I don't use Ki-67. But the point about imprints is well taken. I agree with that. I've also had experiences of judging incorrectly on imprints. Another thing about imprints, since this topic didn't include cytology, maybe it's beyond that. But having heard you, there is a tendency to, in my observation, we pick up fewer megakaryocytes on imprints than on trephine. And for the megakaryocytes, whereas on the trephine, the megakaryocytes just, they are there everywhere, but the imprints have missed. I don't know. I didn't find any reference to this kind of observation. I would like to know if anybody else has also observed this.
And my point is, like, imprint can give us additional information. It is not like we can judge the adequacy of megakaryocytes on imprints. It's the biopsy which is the best to comment upon the adequacy and topographic distribution. But many a times when aspirates are not up to the mark, then sometimes imprints help. In fact, we have detected parasites on imprints when it's like sometimes mirror image of the biopsy, but not all the time. I mean, we cannot take it for granted that it is going to add to the information, but it's good to have imprint. Sometimes it adds to the information, but one has to be extra careful. But we have a few instances where clinicians were not really convinced that why you guys need imprint. You have biopsy, you have aspirate. But I think once they take out the biopsy, taking an imprint adds to the information while reporting on the bone marrow morphology based on the aspiration and imprint smears. And definitely things will be confirmed and further information will be provided by the trephine biopsy morphology.
Thank you. So thank you, Dr. Amrita.
Thank you. Thank you.
Thank you, Dr. Amrita ma'am and Dr. Gayatri ma'am. Dr. Vidisha, ma'am, your question, please.
Good evening, sir. Thank you for the great and comprehensive talk. So my question was on the cases where we have an interstitial nodule, a lymphoid aggregate. So what would be the basic panel of markers that you would suggest other than a 3 and a 20 to see it's reactive versus, a lymphoma where the patient has a moderate splenomegaly, they have not found any lymph nodes anywhere else. And they want to know, is this aggregate benign or is it a malignant one?
Well, there's no end to putting up immunostains, but a few things that you can remember is that you do a 20 and a 3. There's interstitial spillage. I always like to do a CD5. If the CD5 is lost as compared to CD3, then, it's some kind of a gamma delta process or something, or, it is an abnormal process. So by doing some very limited 3 stains, you get a lot of information. Conversely, if that 5 mirrors CD20, then you know that that's some kind of a B-cell lymphoma, such as a mantle cell or a CLL. So some things help, some kind of soft pointers, as I told you about the number of aggregates, the shape of the aggregates, the topography. But yeah, otherwise there is no end to. You can put up n number of markers and still be not very wiser at the end of the day. So maybe, clinical information, as you said, if they tell you if it is a spleen which is enlarged with nothing else, and you would like to check for splenic marginal zone lymphoma or a hairy cell leukemia and things like that. So I would say case to case, it would vary, but I would say 23 and a 5, those are really helpful.
And sir, in cases where the 5 is completely negative, which we generally get with splenic marginal zone. So how do you go about? Because we've had cases in which, the clinician wants a diagnosis because the biopsy looks there, aggregates are there. There's nothing on cytogenetics, but the patient has a spleen. So can we give a definite diagnosis on trephine biopsy is what the question is.
If I see some intersinusoidal localized CD20 positive cells, and I would also tend to do an IgD along with that. But that intersinusoidal localization is something which is very specific for splenic marginal zone lymphoma. So if I see that there is a history of only spleen and I see this splattering of CD20 positive cells, also of note, sometimes splenic marginal zone lymphomas do express CD5, very rarely, about 5 to 10% of the cases. So there are some caveats always here and there. But yeah, if there's interest in sort of localization, I would not hesitate to call it a splenic marginal zone lymphoma.
Thank you, sir. One more question, sir. So malignant histiocytosis. Sometimes we get biopsies. There are lots of histiocytes. Oh, some may be just a a HLH kind of a progression which we are seeing in the marrow. But if we are suspecting a histiocytic proliferation which is not benign, so what are the markers in that case that you suggest? CD68 will mark everything in the marrow. So for that, in that case, sir.
No, so sometimes you need to then do some kind of a molecular analysis, something like a BRAF V600E antibody if you have, or you can do a molecular analysis of it. You can't judge otherwise and say, unless it's just rapidly kind of a, what should I say, malignant looking histiocyte with mitotic activity and a lot of pleomorphism and things, but it's exceedingly rare, to have that kind of a presentation. So in those cases, you would be fine. Otherwise, you'll have to do some kind of analysis. You can also get things like ALK positive histiocytosis. So you can do an ALK, something which tells you that it's clonal. So you would like to do those kind of things like ALK or a BRAF V600E, something which can point towards it not being just reactive, but something which is clonal. So that's how I would approach a case.
Thank you so much, sir.
Thank you, Dr. Vidisha. Dr. Sindhura, your question, please.
Yeah, thank you, sir. It was an excellent talk. Just a few questions. One is about the pre-analytical variable. You mentioned there are, as you said, there are different fixatives used by different labs, and some have preferences over the others. So how do you make sure that your sample is as per the sample that you receive from an outside lab is actually the one which you would prefer? I know that you would receive a lot of samples from outside labs. How do you ensure that they actually are following your prerequisite protocol?
No, I don't think we can control all of that, but from hematologists who send it to you regularly, I just tend to send them the AZF, so that they can plonk it in that AZF and send it to you. Sometimes if you know the pathologist who's doing that processing and is sending it to you regularly, I send them that Hammersmith protocol. That's very useful to kind of, refer to. It's easy to understand. But I agree with you, as with most things in our country, those pre-analytics are out of our hands. A lot of times the processing is done not in-house, but a lot of the small laboratories tend to do it with external labs. And, they have in turn no control on how the third party is actually processing it. That's where they actually use and I learned this, they use the concentrated hydrochloric acid because they're able to decalcify and get the section next day and make the client happy.
Yes, sir, I agree. So we do have those issues, especially when the morphology ends up being very bad when we see the biopsy, and we'll be unable to report. And second thing is, would you prefer EDTA as a decalcifying agent because it would preserve the molecular DNA? Because 10% formic acid, yes, it gives a very nice decal. But do you practice using EDTA for decal?
Yeah, if the bone, not for trephine biopsy as such, because you don't not to do much of molecular analysis on trephine biopsies unless it's some kind of a BRAF or something. But if I do get bones which have been done for metastatic disease, and then I change the protocol to EDTA, because then if it's like a lung, for example, you would want to do NGS on that to check for the solid tumor molecular targets. And in which case I find that EDTA is better than AZF for that. But 10% formic acid, otherwise it's quite a good decalcifying agent. It doesn't harm the marrow too much. It's just a question of relativity between the two. EDTA tends to give you a better yield of the genomic DNA. That's the only thing. I think there's no hard and fast cut and fine rule that you should use that only. It's just my experience that between the two, EDTA gives you a better yield of genomic DNA.
Okay. So another question is about bone marrow infiltration by, say, Hodgkin lymphoma. I know it is not done routinely anymore for Hodgkin lymphoma. Mostly the F3G PET scan is done. But in cases where there is no lymph node diagnosis of Hodgkin, but you see clear Hodgkin infiltration, would you still give a diagnosis of Hodgkin lymphoma infiltration on bone marrow without having a lymph node diagnosis?
No, you would be surprised. There's one every 10 days where I diagnosed a primary Hodgkin, a quote unquote primary Hodgkin on a bone marrow. It depends on the, with how much enthusiasm the treating physician is going to look and seek out that elusive lymph node which is involved with it. No, but it's more common than one would think. And I'm just going to give some kind of a comment on that almost 80 to 90% of these so-called quote unquote primary Hodgkins involving the bone are EBV related. I almost always get EBV LMP1 or an EBER on that. So that's something which I find useful. But I don't hesitate in calling Hodgkin lymphoma involvement in the marrow, even if it's just a primary involvement.
Yes, sir. One last question. So regarding minimally invasive bone marrow, like minimal bone marrow involvement by lymphoma. Say, for example, we run flow for a staging marrow and we detect less than 0.5% or less than 1% abnormal lymphoid cells. Whereas on morphology, it is not detected, like not as a cluster or any collection. So in that case, there is a discrepancy between the flow and the morphology. How do you go about it? Because we do get such questions from our clinicians. Because they say that, what do I do now? You've given info involved on flow and no involvement on morphology. How should we proceed? So what
that's
could be
the nature of the investigation. I mean, as I said, not everything is countable or doable on a trephine. Flow is a much powerful modality of investigation. But again, having said it, and I think Dr. Amit will bear me out. See, for certain lymphomas, it doesn't make a difference. If it's a low-grade lymphoma, marrow involvement would alleviate, they would assume that it's fine. The treatment doesn't change. So unless a treatment is going to radically change, I don't think we should break our heads trying to see if it's 0.5% involvement or a 1% involvement. And I think just talk to the treating physician and try to sort it out. I think that would be the way forward. Is that correct, Dr. Amit? I mean, I'm on the right track?
Yes, sir, you are absolutely on the right track. The treatment may not change, actually.
Yeah.
You are getting a few staging differences there. Basically, the bone marrow is involved or not. That's it, because that is our goal, actually. But ideally, the treatment for the lymphoma will not change.
Thank you. Thank you, sir. An excellent talk. Thank you.
Thank you very much.
Thank you, Dr. Sindhura. We have some questions from the audience. Dr. Nikhil wants to know that any diagnostic clues to differentiate primary myelofibrosis from post-PV myelofibrosis if there is no clinical history to suggest any antecedent for polycythemia vera?
No, you can't. You just need to know that history. Otherwise, it's going to look the same probably.
Dr. Raj Wari wants to know that what is the lower limit cutoff for platelets for doing a bone marrow biopsy?
I think you're asking the wrong person. I mean, I don't do the biopsy. So, Dr. Amit, if you can answer that for me.
There is no cutoff. You can do it in less than 10,000 also. For ITP, we are doing, for leukemia, we are doing. We do not give platelet transfusion before the bone marrow biopsy. Any platelet count, you can go for a bone marrow biopsy. Dr. Savitri Singh wants to know, please tell about the morphology of megakaryocytes in X-linked thrombocytopenia, megakaryocytes in GATA1 deficiency thrombocytopenia, megakaryocytes in Viscott-Aldrich syndrome, and megakaryocytes in other inherited platelet disorders.
I have to say that I have no answer for that. If I had it in real life, I would have had to go and check on the textbook. So I would have done that. So sorry, I don't know offhand these morphologies.
Okay. Dr. Miat Mallar-Shwe wants to know, can other causes of dysplasia, we have to use the same cutoff percentage, like 10% for the MDS, other causes also for dysplasia?
Yeah, but if you don't know the cause, then you don't know if it's MDS or not. So you would still use the same criteria to say the marrow is dyspoetic or not. But if you talk and find out if there's an antecedent viral infection or something, then you would ascribe it to a secondary myelodysplasia. So the question here is that you might want to use those criteria if you're actually going to call it an MDS. So if there's a cytogenetic abnormality, or if there is something on fish to have said that there's something MDS related kind of a cytogenetic abnormality which has been found. So yeah, I suppose you would have to use the same criteria.
So percentage remains the same, 10%. Yeah. And for megakaryocytes, 30%.
That's what 30% is something which I tend to say, because it's such a huge cell, depends on what level and section it has been cut at, you will see so many abnormalities. So unless it's there across the lineage, one should desist from calling megakaryocyte as dyspoetic, because it's a very easy thing to spot, and people tend to over call it, I feel. I mean, I used to do that early in my career as well. So that's my learning, and I wanted to pass that on to the trainees.
Thank you, sir. Another question from Dr. Shilpi Saxena. What is the role of TDT for post-induction or post-consolidation in case of BALL or TALL? Should it be done or not? Especially if the bone marrow aspirate sample is very much hemodiluted for during the processing for MRD during flow cytometry.
No, I guess you would have to do it, but not in isolation, because then you otherwise won't know if these are hematogones or residual blasts. So yes, I mean, if they have a trephine biopsy and the question is that you want to check out for, kind of residual disease, yes, you do the TDT, but along with then 10, 34, PAX5 and 20.
Thank you, sir. Another question from Dr. Nikhil. This is the question. They had an asymptomatic patient with isolated thrombocytosis and bone marrow shows panmyelosis and JAK2 was unmutated. What MPN would you categorize this patient into based on this trephine biopsy?
It's kind of difficult to visualize.
Asymptomatic patient, isolated thrombocytosis, bone marrow shows panmyelosis, JAK2 not mutated. So what would be the category of MPN based on this trephine biopsy?
No, I mean, obviously JAK2 is not the only abnormality, right? There are so many other abnormalities that one needs to rule out. So I would say check for that. And I would like to see the trephine to see what megakaryocyte abnormalities there. Is it hypolobate, hyperlobate, enlarged, clustered, polymorphous or not? So various things. I don't think there's one simple answer to this question, hypothetical question.
True, sir. Another question from Dr. Anju Bharti. What should we do? Should we go for trephine biopsy or cytogenetics if the clinicians are suspecting MDS? What would be better, trephine biopsy or cytogenetics?
I suppose both would be complementary, right? So both should be done. In isolation, I don't think you're going to get answers.
Absolutely. Another question from Yimon Tent. What are the factors which influences false negativity of TCR gene rearrangements?
TCR gene rearrangements on marrow are slightly challenging because of the quantum of the T cells. Even in things like skin, when you do it, you tend to see some kind of there are different clones in it. There are pseudo clones, so you will not get something. But I don't know about false negative. Would just have to be below the threshold of the analytic sensitivity of the test, I suppose. That's the only reason I can think of.
Yes, sir. Another question from Dr. Prerna. Can you please share the EDTA preparation which you said for use as a decalcifying agent, like what percentage, preparation, duration, etc.?
Okay, I could send that to you if you can email that to me.
Sure. So, Dr. Prerna, I will email it to you. Dr. Hita B has a question. How to differentiate between MDS with myelofibrosis versus primary myelofibrosis?
MDS with
MDS with fibrosis versus primary myelofibrosis.
Okay, so primary myelofibrosis, you almost always get a very high ME ratio. That may not be the case with MDS unless it's a del5q. The erythroid cells are still there. They will show you dyspoesis. The megakaryocyte morphology would be different. With PMF, you would tend to get enlarged ones with hypolobate, kind of uniform hypolobate nuclei. With MDS, you will see a lot of variation. You will not see only enlarged and hypolobate nuclei. And then again, whether there's a huge spleen or not, if there's a huge spleen, then that's something which would rule out MDS, but more in favor of an MPN.
Thank you, sir. Another question from Dr. Niru Singhal. What is the normal megakaryocytes count for per high power field and how many field one person should see?
As I said, you tend to see about 2 to 3 per high power field. There is no criteria to see how many fields. I mean, you're supposed to see all the whole slide, right? So just observe the entire slide, I should imagine.
Absolutely. So, Dr. Shashi Bansal, you have got a question?
Good evening.
Hi, Shashi.
I just wanted to know, okay, what kind of panel you use in the suspected case of splenic leukemia lymphoma, like annexin 1, DBA44, and do you use a trap also?
Yeah, so actually, I use for hairy cell leukemia, you're asking?
Yeah, hairy cell leukemia, it's variant.
Yeah, cyclin D1. I mean, of all these, the first thing that I do is cyclin D1. If it's cyclin D1 positive, I'm very comfortable then to do a DBA44 and a trap. Annexin A1 is a very iffy antibody. Sometimes it works, sometimes it doesn't work terribly well. So yeah, I would do that cyclin D1, DBA44 and trap at least. Well, if you have BRAF V600, nothing like it. That seals the diagnosis of a hairy cell leukemia.
So it's not the hairy cell leukemia. Sometimes we are acquiring some cases where the everything is coming negative. Even the annexin 1 is negative, DBA44 negative, 5 negative, 10 negative, only the 20 is coming positive. So in those cases, where to put those cases? So we have to put in the trap or something else. Because there was one case, I have put everything, cyclin D1, everything. It's ultimately what the kind of report is generating is a low-grade B-cell lymphoma. Because annexin 1 is negative, DBA44 negative, cyclin D1 negative, 5 negative, 10 negative. The patient has a pania with a massive splenomegaly. So ultimately, by the flow was also done in that case. In that, there was a 103 and 123 was positive, 11C and 25 was negative. So they are coming in the group of splenic leukemia lymphomas, but classically there was nothing is matching, not even the variant, not even the classical. So in those cases, the trap has any utility of that or any other guidance from you?
No, trap on itself, I wouldn't, trust for anything. That's not very sensitive or specific for a disease. But if it's only CD20 and a massive spleen with no lymph nodes, then I would want to really look very hard for intersinusoidal localization. If I see that, then I would be happy to call it a SMZL then.
But what about the SMZL? In that case, basically the whole marrow is replaced by the cells. So you hardly can encounter any sinusoids.
Okay,
So,
then it's only two diagnoses. Either it's an LPL or a marginal zone lymphoma then, or a hairy cell. These are the three things which diffusely involve the marrow.
Okay, thank you.
Thank you, Dr. Shashi. We have got some few more questions from the audience. Dr. Prerna wants to know that in plasma cell disorders, IHC for kappa and lambda light chain to establish chronality is often very difficult to interpret. So can you suggest if any modifications to the IHC process for this issue?
Yeah, you can dilute the antibody and get it working, or you can do an in situ hybridization, one of the two.
Thank you, sir. Another question from Dr. Ye Ching Lin. Do you do FISH from trephine biopsy section when there is a dry tap? If so, what is your experience with respect to sensitivity of FISH between aspirate versus FFPE from trephine biopsy?
No, I'm sorry, I've never done that before, so I'm not going to be able to answer that query.
Okay, sir. So, Dr. Parimal, you have another question?
Jai, I have one question that sometimes in trephine biopsy, suspected cases of myeloproliferative neoplasm. So you on trephine, you are sure that it is a myeloproliferative neoplasm, but sometimes it is very difficult to subcategorize. And then you put that it is a MPN not otherwise specified. So have you come across such type of cases and how you approach such type of cases? Because clinicians want that, give me that BCR-able negative MPN subcategorize. But sometimes megakaryocyte morphology are not typically of any of the BCR-able negative MPN. So how you approach in such type of cases?
Yeah, you tend to see this more often than not. They're not very rare, but once you see many, you will see quite a few of these things where they don't slot into a particular disease. What I then tend to do is I talk to the physician. I want to know if there are history of infarcts and stuff, then you would like to think of PV or something in that. ET is something that, again, short history and thrombocytosis, isolated thrombocytosis with nothing else. So ET would come there. Sometimes myelofibrosis, is it secondary, long-standing? Is there a prior history of MPN which they haven't been told? So these are the ways I go about it. Sometimes they just remain unclassified. But again, for PV and all, I suppose they want to put somebody on aspirin kind of prophylaxis and things like that. So you just need to discuss it out and do it. But no, there's no simple way to approach this problem otherwise.
Okay. Thank you. Thank you.
Thank you, Dr. Parimal. I've finished all the questions from the audience. Anybody want to ask any other question to Dr. Jay Mehta? So if there are no other questions, well, sir, so wonderful lecture by you as always. Always good to hear from you. And what a fabulous question answer session with you, sir. Thank you so much for solving all our doubts. It was always worth learning from you. Every points were very, very crystal clear. Fabulous lecture, wonderful lecture, and perfect lecture by you. Thank you so much for being with us this Saturday evening. And thank you, all of you, all the discussants over here, and obviously all the audience for joining us this Saturday evening. Thank you so much. See you tomorrow, Sunday, with another beautiful lecture tomorrow at 11:30 a.m. onwards. Well, thank you so much, sir.
Thank you.
Thank you. Thank you, everyone.
Thank you, sir.